Hey guys, I'm Dr. Buffy, and today I'm super excited because I'm going to be having a conversation with my dear friend, Dr. Peter Patterson, and we're going to be discussing the importance of having an infection prevention and control program combined with an antibiotic stewardship program. Hey, Dr. P, great to have you today.
Thanks for having me.
Love to have you just provide a brief intro for those watching today.
Sure. Well, my white hair says I've been doing this for a long time, actually 50 years. I'm a 50-year physician and a third generation. My father and grandfather were also physicians, and I've been spent most of my career in the clinical laboratory as a laboratory director and more specifically director of microbiology in a couple of places. And I've been an infection control officer in multiple hospitals, in the past. And I've been in the post-acute long-term care space since about 2012.
And we met, gosh, it's been a number of years now. And that's why I love working with you and your innovation. And today I just wanted to have a conversation about the importance of antibiotic stewardship. We're in the middle of this pandemic and we're dealing with this crisis. And so we're talking all about infection prevention and control in the long-term care, the nursing homes, but we're not really talking about the importance of antibiotic stewardship and all the other infections that we're dealing with. And, you have a best practice for the antibiotic stewardship. And maybe you could just talk a little bit about your program and how you've supported nursing homes with antibiotic stewardship.
Yes, sure. Well, starting back, I worked with a nurse, an assistant director of nursing at Glencroft in 2014 is when we started on a program of antibiotic stewardship, developing a protocol that was really based on 3 or 4 key ideas. The first being that you need to understand what is the truth about antibiotic resistance, and which is the root cause of antibiotic resistance, which is widespread in our world now, like a public health emergency. The root cause is overuse of antibiotics. And more specifically, with a little more edge, it's due to patients being treated with antibiotics for infections they do not actually have. They don't fulfill a good case definition of infection. So there's a bit of epidemiology built into this. So that's basically the truth. And then the next idea is you need to collect data in a way that's meaningful. And the most important thing to understand there is you don't want to look at antibiotics by class, like so many pounds of penicillin per month, or tetracyclines or gentamicins, the aminoglycosides. Instead, you want to survey antibiotic use by clinical syndrome. Specifically, the 3 commonest ones are urinary tract infection, pneumonia, and round wound infections like a pressure ulcer. So I like to say that the main problems are not actually UTI, not actually pneumonia, and not actually a wound infection, because people are misled mostly by collecting microbiology data and forgetting about the clinical. So that's the main 2 ideas. And the third idea is once you get the data that shines a light or brings to the surface the fact that there is overuse of antibiotics going on, then you have to find a way to feed that information data back to the practitioners who are doing the ordering so that they can, if you like, see themselves in the mirror. And really, you don't have to do anything other than that. If people can see themselves in the mirror, they'll self-correct, so to speak. They'll say, oh, I see. Now we got to do it differently. So that's the flow of how it goes when it's going well. And my life's work for the past half decade or so has been getting facilities and infection preventionists to do that.
So I love that. And I love the 3 key areas. And, often what I hear from the infection preventionists within this healthcare setting is they just don't know where to start. I too love data, and it's so important that we use the data to tell the story. And so if I'm a new IP, where do I start with this? Like, what are some basic areas that can help me get going?
Well, there's 2 things I think that need to happen right at the front. The first is you need a partner. You need some connections to your own facility. And specifically, I'm talking about what the CMS calls the senior triad, which is the administrator or executive director, whatever they're called, the director of nurses, and the medical director. So the first thing that needs to happen is that the senior triad has a conversation or works with the IP in such a way that they become the facility sponsors of the antibiotic stewardship program. So that needs to be put in place first. And the next thing I always smile when I say it is the IP has to get over what IPs want to do, which is to get out there and press the flesh on the floor, and they're not so interested in collecting data. They'd rather not have to collect data. So those are the two things that have to get over first, and then you have to decide if they have an electronic record, which most people do now. Then you want to find ways to collect information in the electronic record that does things like for new starts of antibiotics. You want to know that so that you can then say, of all the starts in antibiotics for whatever syndrome they're treating, how many of them, what fraction meet a standard case definition? And that's part of your data and the format for reporting. So those are basically the most of what you do with the IPs is a combination of two things. First of all, you train them in McGear criteria for case definition. So it means you have to kind of get them over the fact that the default by people is to just look at the microbiology data. Right. And people's default way of looking at it is to say that if there, let's say 100,000 colonies of E. coli in a urinary tract culture, that by definition is a UTI. Right. No, it is not. If there's not a compatible clinical definition according to McGear criteria. So that's the first thing that I usually end up doing with the IP, and then training them how to collect and format the data. Usually infection prevention nurses have to report monthly at some kind of quality meeting. And so you help them, do the monthly reporting and then a summary at the end of every quarter so that people can see quarter by quarter what's going on.
So Dr. Patterson, you had mentioned before that this is really an emerging issue. And what happens if we don't conduct antibiotic stewardship within our healthcare settings? What are the consequences if we don't invest our time and energy into this work?
So the consequences of not doing antibiotic stewardship well or properly are quite serious. We are at the edge of the cliff with regard to widespread antibiotic resistance, where a lot of antibiotics don't work anymore, and people are, increasing numbers of people are dying of infections that can't be treated with any antibiotic. And so that's the bad news. The good news is that most antibiotic resistance is local. It's not like nationwide or global. So you can impact antibiotic resistance in the facility itself by beginning and doing good antibiotic stewardship, like decreasing the overuse of antibiotics will, over time, 6 months or a year, lead to decreased amounts of resistance, and antibiotics will be better used, more effective. So that's like the promise of antibiotic stewardship, and the price is that we're going to be in the post-antibiotic era, which so-called, which would mean that all the advanced things that we do in healthcare and medicine will no longer be possible. Organ transplantation, serious surgeries, all that kind of thing, intensive care of any kind that depend on effective antibiotics to cover certain procedures or certain happenings, clinical happenings with a patient will no longer be possible, or will be very difficult. So that's why it's important to be getting this one right, and why, by the way, the regulatory agencies, CMS and FDA and everybody are hot on this topic now because it's so important. It's become a regulatory requirement.
Absolutely. Thank you so much, Dr. P.
You're welcome.